It's my pleasure to welcome you to this advocacy event, Beating Liver Cancer in Europe, the empowerment of prevention and early detection under the patronage of the Slovenian presidency of the Council of the European Union, organized by the European Association for the Study of the Liver, EASL, together with the European Liver Patient Association, ELPA. My name is Thomas Berg. I'm the EASL Secretary General, and I would like to thank you, the Slovenian government, for supporting us in the organization of this event during the presidency of the Council of the European Union, but also all organizations in Slovenia who support us, which are, among others, the Medical Faculty University of Ljubljana, Slovenian Association for Gastroenterology and Hepatology, Slovenian Patient Association with people with hepatitis, Cancer Patient Association of Slovenia, and also the WHO country office in Slovenia. While we are here today, liver cancer numbers are on the rise, but public awareness for it appears to be lower than for other cancers, probably as a result of the stigma attaching to patients with liver disease. We need to act urgently to change this scenario, to detect and treat liver cancer early, or even better, to prevent this disease and prevent patients from suffering from liver cancer. It cannot be overestimated how important it is for patients with liver cancer in Europe and the groups that support them to receive the attention they deserve, not only from healthcare professionals, but also from our policy makers. So thank you all for being here today, all together around the table. We are grateful and thankful to all those who have contributed to making this event happen, especially to the representatives of the European institutions and the Slovenian government who are present to hear our concerns related to liver cancer trends in Europe. I hope this event will be the start of the beginning towards a new era of cancer prevention in European patients with liver disease. So over to the president of ELPA. Over to you, Marco.
Thank you very much, Professor Berg. It's a privilege and an honor to be part of this event. I do want to stress that thanks to all the people who are involved in organizing this event. Facing liver cancer diagnosis is never easy. And with this event today, we want to show and together with the decision makers discuss what would be the best appropriate way for European Union to move forward. In regards of the Slovenian government, I would express my deepest thanks and acknowledgement that this issue will be high on the agenda. If you are a liver cancer patient and you live in different parts of Europe, you receive also different possibilities how to be part of the healthcare system. So all this will be shown today, and I'm honored to be part of such a high-level panel from representatives that are making a decision. Usually we say it is good to send a message to the stakeholders who are the decision makers, but today I'm proud that we have the decision makers at the table. So we are sending a clear message not to the stakeholders, but we are together with them deciding what is the best course of action to take in the future. This will be beneficial for liver cancer patients. This will be also beneficial for all people who are facing liver diseases in European Union. So thank you all, and I'm looking forward to the clear discussion about the presented data on how is the position of liver cancer today in European Union. And we made an effort to bring in patient representatives from different parts of European Union just to show what can you expect if you are a liver cancer patient. And at the end of this welcome remarks, I would stress that EASL is one of the few, or maybe only one, organization of doctors and medical researchers in the field of liver that has involved patients from the beginning. So ELPA is here for 16 years, and EASL and ELPA collaboration has gone on for the last 16 years. So thank you very much for involving patients also in the decisions and discussions about how to proceed. Without further ado, I would go into the opening remarks. So it's a distinguished honor to invite Slovenian politicians to do the welcoming remarks. We should remember that this event is organized under the presidency of the Slovenian to the Council of European Union. And in that frame, we are sending a message that liver cancer patients are important, and the liver cancer patients do need additional steps that are needed to take in order to improve the position of liver cancer in Europe. So for the opening remarks, I'm welcoming Igor Zorčič. He's the president of the National Assembly of Republic of Slovenia. Mr. Zorčič, please, for the opening remarks. Thank you.
Commissioner Kyriakides, Minister Poklukar, distinguished representatives of the organizers, ladies and gentlemen. It's an honor for me to be able to welcome today the best national and European liver cancer experts. Following the outbreak of the pandemic, national health systems have found themselves in truly trying circumstances. Therefore, warnings from health professionals, namely that cancer doesn't rest, should not go unheeded. I especially welcome the initiative of the Ministry of Health to sponsor this high-level event during the Slovenian presidency of the Council of the European Union, helping make sure the goals of Europe's Beating Cancer Plan are boldly implemented. While the decrease in mortality from some cancers over the past years, mainly thanks to advances in medicine and pharmacy, vaccines, effective screening programs, and increased public awareness is undoubtedly a cause for celebration, it is nevertheless extremely worrying that fewer malignancies were detected during the pandemic. This could result in malignancies being detected at an advanced stage when treatment and rehabilitation are more demanding and expensive, and the end resultant uncertain. Liver cancer is no different. Professionals warn us of an impending new pandemic, that of liver cancer. Luckily, most hepatic diseases are preventable. Today's event can therefore also serve as an opportunity to send a message to lawmakers. Properly regulated marketing of sugary food items, hidden trans fatty acids, and alcohol could contribute to greater awareness of risk factors such as obesity and type 2 diabetes. I also believe that Slovenia will set a good example for the European Union as a whole by carrying out targeted screening for liver cancer. I'm confident that today's webinar will lay a solid foundation for the successful implementation of Europe's Beating Cancer Plan. Thank you.
Thank you very much. And now it's my pleasure and privilege to welcome and to introduce Mr. Janez Poklukar. He's a Minister of Health of the Republic of Slovenia, and to invite him for his opening remarks.
Dear esteemed guests, I'm delighted to welcome you at this important meeting on action for prevention and early detection of liver cancer. Slovenia placed cancer on the EU agenda in 2008, and I'm pleased that the European Commission adopted ambitious Europe's Beating Cancer Plan. It is time now to focus on the implementation. Liver diseases are the second leading cause of premature death in people of working age in Europe. Also, most liver diseases are preventable. They often lead to the development of liver cancer. It's the sixth most common cancer and the third leading cause of cancer death. Over the last decades, the incidence of hepatocellular carcinoma, which is the most common liver cancer, has continued to increase. Figures clearly show that we must tackle the main risk factors for liver cancer more efficiently. We know that reducing harmful alcohol consumption is the most powerful strategy to prevent new liver cancers. In some countries, which including Slovenia, alcohol is the most important risk factor, and we are struggling defining consistent alcohol policy to address this issue. We must also continue to tackle obesity and type 2 diabetes through limiting marketing and promotion of sugary food items. In addition, we must ensure access to hepatitis B vaccination and enabling treatments for hepatitis C and B to prevent liver cancer associated with both viral infections. Aside all these strategies, we should look at the evidence if the already existing target cancer screening should be extended. I'm looking forward to the European Commission proposal for an update of the Council recommendation on cancer screening, which will address this topic. Slovenia is preparing the third national cancer plan, which is in line with EU Beating Cancer Plan. We put a lot of attention to primary and secondary prevention. Prevent the preventable is our motto. We successfully manage viral hepatitis with the aim to its elimination that serve as one of the WHO best practices examples and will be presented at this meeting. Besides, Slovenia is also well recognized for its commitment to tackle health inequalities, especially by reinforcing the links between the Western Balkans. I would like to thank the organizers for raising awareness of the importance of chronic liver disease prevention and prevention of liver cancer. Slovenia stands ready for sharing good practices and collaboration in the future. Thank you for attention.
Thank you very much. Now we come to our session. So the meeting is organized in two different sessions. The one before the lunch break, session 1, is related to liver cancer prevention and health promotion. And after the lunch break, we have session 2, mainly dedicated to early detection and liver cancer screening. There are a few housekeepings I would like to share with you in the next slide. So please ask your question with a Q&A function, and we will keep your question and we will then discuss it after each of these sessions where we have a Q&A part. Please be aware that this meeting will be recorded, also for the purpose that it can be viewed on demand. And we would be very grateful if you give us your feedback, whether you enjoyed this meeting and what is your feedback to this overall event and to the speakers. So thanks a lot for that. And then I would like to give you a brief overview on the first session. And I will first give the floor here to Maria Bucci, who will present EASL's efforts to make the voice of the entire liver community heard by the European institution with an open letter on the treatment and prevention of liver cancer. And we have then 4 honorable EASL experts, and they will then highlight the burden of liver cancer in Europe and the possible holistic approach to cancer prevention using liver cancer as an example. Afterwards, we will discuss with key opinion leaders from the European Commission and the Committee of Regions what can be done at the EU level to change the sad landscape of liver cancer in Europe. And Marco, we have also 3 patient representatives, and perhaps you can introduce them.
Yes, thank you very much, Thomas. So we will have this part as one of the really important part, because every patient advocacy starts with a good data. So we have patients from 3 different countries that will present what is happening in the countries, just to have a feeling of what is going on if you are a liver cancer patient or a liver patient from different parts of Europe. But in regards of the expert view or expert opinion, we should stress very clearly that any kind of patient advocacy starts hand in hand with a clear data from medical experts. So we are looking forward to this first part, and on second part, we will go step by step to present what people that are faced with liver diseases are experiencing in different parts of Europe.
Thank you, Marco. So now I will give the floor to Professor Maria Buti. Maria Buti is EASL's policy counselor and chief of internal medicine and hepatology at the Hospital General University Vall d'Hebron in Barcelona, Spain. So please, Maria, present the EASL open letter.
Good morning, everyone. It is my honor to present today EASL open letter 10 asks to improve liver cancer care and prevention in Europe. EASL recently launched advocacy activities for a better inclusion of liver cancer in European health policies. This letter is addressed to the President of the European Commission, Ursula von der Leyen, the members of the European Parliament, and the President of the European Council, Charles Michel. The letter includes 10 asks for improved liver cancer care and prevention in Europe. We are very proud of this initiative and strongly hope that this ask will be heard by the European policy makers. Liver cancer is on the rise, whereas other cancer incidence rates are declining. In fact, there has been a 70% increase in liver cancer-related mortality. Liver cancer is the 6th most common cancer and the third most frequent cancer-related mortality in recent years, making it the 6th most frequent cause of cancer-related death globally. Liver cancer occurs mainly in patients with liver cirrhosis. And liver cirrhosis, and particularly liver cancer, are usually diagnosed late when the life expectancy is short. The most common risk factors related to liver cancer, chronic viral hepatitis, obesity, and fatty liver disease, and alcohol consumption are factors that we can treat or even we can prevent. Here, the importance of this open letter. Now, I will quickly go throughout the main message of this 10 asks. First, raise awareness, prevention and management standards. Second, improve access to better disease management for all patients. Third, enhance cooperation among hepatologists, oncologists, and other healthcare providers. Encourage collaborative clinical management guidelines, and also reduce existing inequalities and ensure the highest standard of care for our patients. Very important, introduce liver cancer screening to national schemes and implement preventive measures to reduce our risk factors. I have mentioned that we can modify these risk factors. Set up specific patient registries to collect data and share data to close the gap between medical knowledge and practice. And then mobilize all interested parties to get actively involved in these 9 asks. The European environment allows us to be active and influence health policies and to push for implementing measures for liver health. There is a strong political commitment for cancer, and the amendment 623 on liver cancer screening of the Becker report is under consideration. EASL, with a large community engagement, is encouraging to keep liver cancer screening in the plan. And to show that this is really important, we have a large community engagement. As you can see here, the main associations, patients associations such Liver Patients International, ELPA, medical organizations, AA, SLD, other organizations, and also a large number of individuals have signed or endorsed this 10 ask. Help us fight liver cancer in Europe. I think this is really important. So I will ask all of you to support this 10 ask. Thank you very much for your attention.
Yeah, Maria, thank you very much. This is really important. And now we would like to come to the burden of liver cancer in Europe. And it's my pleasure to introduce Professor Peter Galle, who is a liver cancer expert from the University Medical Center from Mainz, Germany. Please, Peter.
Thank you for the opportunity to share some data on the burden of liver cancer in Europe. These are my potential conflicts of interest with respect to hepatocellular carcinoma. This is the structure of my presentation, and I will start with epidemiology of liver cancer. Worldwide, it's actually a very common cancer, and in most years ranks at number 2 as leading cause of cancer death worldwide. In the Western world, in developed countries, it's less common, is rather a rare disease, but nevertheless occurs. These are data for Germany, and you see the cancer registry data and the dominance of male patients. What we observe with some concern is that there is an increase in numbers here for men and women with respect to primary cancer of the liver over the years, estimated data here. And the reason for the increase, as it's also observed, for example, here in UK, is that we see certain rise of non-alcoholic fatty liver disease as an etiology, which is in some parts of the world already a dominating etiology. We have two types of primary liver cancer, those developing from hepatocytes, more common, 80 to 90%, and those developing from cholangiocytes, bile-producing and transporting cells, 10 to 20%, and then rare tumors which are not to be discussed today. There are defined risk factors for the development of hepatocellular carcinoma and also cholangiocellular carcinoma, and that is alcoholic cirrhosis, viral hepatitis, non-alcoholic fatty liver disease, as I said, with an increasing incidence, and other contributors. The etiologies are treatable, and the risk factors are known. In that setting, it's actually disappointing that if we go through these stages, that the majority of our patients today in Europe are diagnosed at a stage where curative intent interventions are no longer possible, as for example would be transplantation or resection. So most of our patients are not able to receive these curative intent treatment options. Nevertheless, there's also some light at the end of the tunnel in terms of systemic therapy. We have seen tremendous progress in the treatment for liver cancer. And as an example, the most recently developed now new standard of care is immunotherapy with atezolizumab and bevacizumab, resulting in a median overall survival in rather advanced stages, almost 20 months, which is significantly longer than what we used to have in the past. There is also an economic burden of liver cancer. It's not as high as with respect to colon cancer, but with 4 billion euro per year, it's quite significant, ranging between esophagus and stomach cancer. In summary, Mr. Chairman, ladies and gentlemen, liver cancer worldwide is a very common and very deadly tumor, and it is on the rise in the West. Hepatocellular carcinoma is the predominant pathological type of HCC, followed by cholangiocellular carcinoma. We have seen this rise over the years in most European countries, and projections go that this will continue in the future. We have defined risk factors: viral hepatitis, alcohol, non-alcoholic fatty liver disease. Patients with advanced liver cancer have a poor prognosis, but the prognosis is at least improving due to new systemic interventions. There's a significant economic burden to the healthcare system from hepatocellular carcinoma. Liver awareness, HCC awareness, would be important to get this tumor diagnosed at an earlier stage. Thank you for your attention.
Thank you very much, Professor Galle, for setting the stage on liver cancer burden in Europe. Now it gives me my pleasure to introduce Professor Peter Jepsen. He's an EASL Policy and Public Health Committee member and an hepatoepidemiologist at Aarhus University Hospital in Denmark, and who will give this talk on the importance of prevention of liver cancer with vaccination and treatment. Please, Peter.
Yes, hello everybody, and thank you very much for the opportunity to give this talk on the prevention of liver cancer with vaccination and treatment. I've no conflicts of interest. We know that between 80 and 90% of our patients with liver cancer have an underlying chronic liver disease, liver cirrhosis. And liver cirrhosis in itself has a very poor prognosis, even without liver cancer. So we can see liver cirrhosis as a stepping stone on the path from a healthy liver to liver cancer. So we can really kill two birds with one stone by targeting the risk factors for liver cirrhosis and for liver cancer. And they are viral hepatitis types B and C, alcohol, and obesity. What you see here is a map of Europe, and it shows the incidence of liver cancer in 2020. And you can see that the incidence is higher in the southern part of Europe than in the northern part. And these geographic differences really reflect differences in the prevalence of viral hepatitis. Viral hepatitis type B spreads from mother to child at birth, and it spreads between children. In adolescents and older people, it spreads as a sexually transmitted disease, and it also spreads through intravenous drug use. When we talk about prevention of hepatitis B, vaccination is really the key thing. We must vaccinate all children against hepatitis type B. For those who are already infected with hepatitis B, we have treatment, but that treatment is often long-term, sometimes lifelong. And the aim of this treatment is to prevent development of liver cirrhosis and liver cancer. It also reduces the risk of transmitting the infection to other people. Viral hepatitis type C can also spread from mother to child at birth, but in Europe, spread through intravenous drug use is really the main culprit. And because the virus was only discovered in 1989, many people were infected through blood transfusions received before that time. When we talk about prevention of hepatitis type C, treatment is key because there is no vaccine available. But over the past decade, we've seen a revolution in treatment. So our modern treatment is really curative, and essentially all people can be cured with a short, often 12-week treatment course. That is why we have the treatment as prevention paradigm. By treating hepatitis C, we can prevent liver cancer. When we talk about alcohol and obesity, we know that hazardous alcohol use and obesity cause liver cirrhosis and liver cancer. And of course, they cause other diseases and injuries too. So we can reduce the incidence of liver cirrhosis and of liver cancer by tackling these risk factors. But in fact, the prevalence of obesity is going up. And in many countries, the prevalence of hazardous alcohol consumption is going up too. Of course, we have no vaccination against alcohol or obesity, and also we have no really effective treatment. So what we need here is policy interventions, taxation, reduced access, minimum pricing, restrictions on marketing, and information and support. So these two graphs illustrate how deaths from liver disease fell dramatically during the two world wars in countries that imposed restrictions on alcohol sales, France and England and Wales. And we saw no such reduction in deaths from liver disease in the United States and Canada. And to the right, you can see a close-up of the time trends in England and Wales, where you can also see the alcohol consumption during the same years. And what we can see is that deaths from liver disease and alcohol consumption really run in very close parallel. And that's really the type of evidence we have that these interventions work. We have what economists like to call natural experiments, where different countries introduce different policies at different times. Now we can see that the incidence of liver cancer has gone down in countries that implemented hepatitis B preventive measures first. We can also see that the incidence of liver cancer correlates with the prevalence of obesity over time and over place. We know that in individual patients, the risk of liver cancer goes down after successful treatment of hepatitis C infection. So in summary, we focus on viral hepatitis types B and C, on alcohol and obesity because they cause liver cancer and liver cirrhosis. For hepatitis B, vaccination is key. Treatment is also available. For hepatitis type C, treatment is the key. For alcohol and obesity, we need policy interventions. Thank you.
Yes, thank you so much, Professor Jepsen. Thank you, Peter, for these clear words. And I think quite in line what we have said is that we will now get an example from Slovenia on viral hepatitis elimination. And this will be presented by Professor Moka Maticic. Professor Maticic is an EASL Policy and Public Health Committee member, an infectious diseases and internal medicine specialist from the University Medical Center in Ljubljana, Slovenia. So please, Moka.
Thank you, Thomas, and good morning, ladies and gentlemen. It's really a great honor and privilege to be here with you today. So as we've just heard, treatment works as prevention of liver cancer, particularly for hepatitis C, which is a curable disease. And with the advent of new, highly effective and safe drugs, in 2016, the WHO set up the first global health sector strategy to eliminate viral hepatitis as a public health threat and to decrease HCV-related mortality due to cirrhosis and liver cancer by 65% by the year 2030. But in reality, in Europe, only a quarter of HCV infected have so far been diagnosed, and only a third of them have so far been treated. The problem is that the natural course of HCV infection usually progresses silently for decades, and the infected are usually unaware of it. Besides, HCV infection most commonly affects the marginalized, the vulnerable, and the underserved populations, raising inequity in its management. So it's of utmost importance to scale up HCV testing and treatment and to find and cure the infected as early as possible. Well, in a 2 million population of Slovenia, the HCV prevalence study was unfortunately not performed. However, in the early 90s, several studies revealed the prevalence, high prevalence in some high-risk populations. And in 2015, it was shown that 2/3 of infected reported drug use as the mode of infection. The management of HCV in Slovenia has been recognized by the WHO as a good practice example. It all started way back in 1997 when the National Strategy for Management of Hep C was established nearly 25 years ago, just by integrating the continuum of services such as HCV testing and treatment into routine healthcare activities. And since then, hepatitis C has been treated in 5 centers around the country, mostly by infectologists. It's been available and accessible to everyone and covered by the National Health Insurance System with no restrictions. In 2007, special focus was directed to people who inject drugs by integrating 5 viral treatment centers and 18 centers for treatment of drug addiction. And this system very quickly yielded some amazing results in treatment rates. At the advent of new drugs, model projections showed that WHO elimination goals are feasible by 2030 by slowly increasing the testing and treatment rates. But to speed up this process, accelerating testing and treatment rates was needed through active case finding. So an algorithm for testing based on risk factors, extrahepatic manifestations, unusual signs and symptoms, and so on, was introduced into a routine clinical practice. And testing in Slovenia can be performed either within the healthcare system or within the community. And the most recent reports show practically no positive HCV results within testing of the general population. But for the population at high risk for HCV infection, active case finding was precisely performed for those who are under regular medical supervision, as well as for special populations such as people who inject drugs and prisoners. So by 2018, a so-called microelimination was completed in several high-risk populations. It means that there are no more Hep C cases among patients with hemophilia, among patients on hemodialysis, among organ transplant recipients, and among HIV co-infected. As for people who inject drugs, the interventions were adapted to their specific needs. So in those managed at various programs, the treatment rates, as you can see here, and treatment results turned out to be very well. However, in others, mobile outreach units will be introduced next year for testing and linkage to care. Taken together, all those data presented and guesstimating the baseline national HCV prevalence at 0.23%, in Slovenia, so far, estimated 86% of infected have been diagnosed, and estimated 62% of infected have so far been cured. But the burden of HCV-related liver cancer in Slovenia has so far not been evaluated. However, a closer look to a very well-studied cohort of hemophiliacs that were all infected before 1993 and have eliminated hepatitis C has shown that among 73% of infected, 3 of them developed liver cancer, but 1 of them refused treatment of Hep C, 1 was late presenter, and 1 was unsuccessfully treated with interferon. So taken together, the knowledge on liver cancer and national data on HCV, the management of hepatitis C, particularly accelerating and treatment in accordance with the National Clinical Practice Guidelines, has been included in the 3rd National Cancer Plan that has just been prepared. So to conclude, ladies and gentlemen, hepatitis C is a curable disease. Treatment works as prevention of liver cancer, but it's very important to develop a comprehensive Hep C national strategy and/or action plan to eliminate hepatitis C, to build integrated HCV test and treat models of care, to make them simple and patient-oriented. It's important to fight stigma and discrimination, and last but not least, to include testing and treatment for HCV into the National Program for Cancer Management. Thank you very much for your attention.
Yeah, thank you, Micah. Very interesting, great effort. Congratulations to your team and Slovenia. And so I would like to hand over now to Marco Korniak, introducing patients from different countries and as representatives of the patient perspective. Please, Marco.
Thank you very much for the floor. So when we were discussing who to choose to present the patient cases from different countries, we took into the account the positions that were presented at the European Parliament by Slovenian Minister of Health, and we selected the countries that we think are the most representative in the focus of the Slovenian presidency to the European Union. We will have the first presentation done by Professor Teresa Casanovas. She is the leader of the group of patients from Spain, and the floor is yours.
Thank you. Good morning. Thank you for your introduction. ASCAT is a liver patients association. Headquarters are sited in Barcelona. Was created in 2000 by people who were seeking information and treatment for hepatitis C. The objectives since the beginning have been to give information and support to patients in relation to liver diseases. ASCAT is an ELPAS founding member. In 2017, we changed the name of the association, and instead of focusing only on viral hepatitis, we consider all liver diseases. Our objectives in relation to liver cancer, HCC, are prevention and awareness. We know that cirrhosis of any etiology is the strongest risk factor for HCC, and every year from 1 to 4% of patients with cirrhosis will develop HCC. The main risk factors for cirrhosis and HCC developments are hepatitis B and C, alcohol-related liver disease, and metabolic-associated liver disease. And related to increasing awareness, we know that many cases of HCC are preventable, but early diagnosis is challenging due to the majority of patients have no symptoms. So early diagnosis with a surveillance of HCC every 6 months through ultrasonography is recommended by clinical guidelines due to the better therapeutic options if we may have an early diagnosis. Therefore, we need optimized early diagnosis and optimized treatment and care. I would like to highlight 2 recent developments in Spain in the field of HCC. First, since patients with HCC have 2 diseases, cirrhosis and liver cancer, it is important the updating and first clinical practice guidelines published in Spain with the consensus among the multidisciplinary team involved in the diagnosis and care of these patients. And the second one is the commemoration of the 35th anniversary of ECLC staging system. Thank you for your attention.
Thank you very much, Teresa, for your presentation. So we will just fast continue forward in the scope of Slovenian presidency and the review of the region that Slovenian presidency has come forward for. We were saying that we will look at the healthcare systems all the way to Israel. So it's my pleasure to welcome the next speaker, who is the leader of the patient associations from Israel, and he will present the liver cancer in Israel. Welcome, Mr. Julio Bullman.
Thank you very much, Marco. And thank you for the invitation in general to participate in this event. I am Julio Burman, one of the founders of HEADS, the Israeli Association for the Health of the Liver, and also Vice President of Israel. We founded our association in the year 2000, starting taking care of people with hepatitis C. After we extend to hepatitis B, and now with fatty liver, rare diseases, pediatric diseases, and liver cancer. Our mission is to help patients prevent liver diseases and educate public, working together with stakeholders. Next slide. In Israel, our population is approaching 10 million people. On average, there are 250 cases of new liver diseases, of new liver cancer each year. Most of them, of course, ACC, but we have also cholangiocarcinoma, due mainly to rare diseases, to autoimmune diseases like PSC. And regarding to awareness and prevention campaigns, they have been done by the patient associations with the collaboration of the associations of doctors, liver doctors, oncologists, but I have to admit that they have not been done by the system, by the government, by the Ministry of Health. Only the patient association and the doctor has been taking care and trying to increase the awareness and prevention of liver cancer. Also, our association lobbies concerned politicians, and we create a coalition with the doctors and the media in order to influence those that are making the decisions. So these are part of our activities in the Parliament of Israel. Now, even regarding to access to treatment, we have in Israel, every citizen has social security and is covered all the treatments for any disease. So regarding to liver cancer, also we have in the reimbursement now the best treatments for taking care, especially of terminal liver cancer. So we have but the problem is that these treatments are in the center of the country. They are not in the periphery. So we have ablation, resection, transplant, TACE, SIRT, systemic therapy, and also multidisciplinary teams that are taking care of the liver cancer patients, but not in the periphery. We need, of course, that the major problem is the lack of awareness of the risk factors that conduce to liver cancer. So, and unfortunately, the detection occurs in middle and advanced stages. And this is something that we can and must prevent it. We must find better markers which will enable early diagnosis and save lives. Thank you very much.
Thank you very much, Mr. Human, for your presentation. And we will just quickly move forward. So you have seen what is happening in Spain, you have seen what is happening in Israel. And one of the regions that Slovenian presidency is concerned also about is the region of Eastern Europe. And from Eastern Europe, it's my pleasure to welcome here among us Marinela Debu. She is the president of the Patient Association from Romania, and she will speak about patients in Romania. Ms. Debu, the floor is yours.
Thank you. Thank you for this invitation. I want to tell about us. We are working from 2019. We are starting as with the association from 19th of May 2009, when it was World Hepatitis Day. We are a member of ELPA, World Hepatitis Alliance, and JANT. We're starting with this association. Our principal objective is also to increase screening and access to the treatment for patients with liver disease in Romania. Since 2019, we are in some regional part of the country where it's very important, and we are in partnership with civil society and healthcare authority. This means doctor society, who are very important for us. How we work: meetings with patients. We try to have local meeting and national meeting, awareness campaign from All Hepatitis Day or from Mother Day, or very dedicated. We have our website, we have online training for patients and partnership with other organizations. And if you want to visit, our page is hepato.ro or Hepato Romania. What I want to present today, it was a screening program case example. I have this data with supported with Professor Liana Gheorghe, who is a doctor, gastroenterologist at the Fundeni Clinical Hospital, the most important hospital from my country. Like you know, Romania, it is on top with liver cancer and also with cirrhosis. Just in 2019, according with official data, more like 2,800 people died because of liver cancer. Is 6th leading cause of mortality to the cancer in my country. Romania has the highest mortality due to the liver cirrhosis in Europe. The situation was exacerbated by COVID-19 pandemic situation, and we think the cases of cancer increase it also with this, because like you know, people drinking, the testing campaign is not like before. But in 2019, just before with the beginning of the COVID-19 pandemic, an extensive liver cancer screening starting can stop liver cancer. It was coordinated by Romanian Association for Liver Disease and Romanian Society of Gastroenterology, and supported by a pharmaceutical company. Priority of this project, it was patient with NASH, NAFLD, with F3 or F4 post here, patient with hepatitis C on therapy, or patient with hepatitis B with F4, F3. For information and awareness, it was a prepared poster with information about who should come for detection in gastroenterology infections in the internal hospital. Family doctors are involved with some courses, and the use of non-invasive means such APRI, FIB4, or other unupdated markers for depistation of the fibrosis. Each patient who has entered in the program receives a booklet with the next appointment and personalized information. The idea is a caravan and monitoring at every 6 months. Unfortunately, because of the pandemic situation, we hope to continue in soon. The main university of the center in the country are involved when gastroenterologists and oncologists can to multidisciplinary collaborate. The goal of the program is to screen and detect patients with hepatocellular carcinoma at early stage and not to establish a national registry of cancer, liver cancer. In this moment, we have just regional registry. Like I told you, pandemic situation affected also present as a program, because you know Romania it's leader not just in Europe with COVID-19. My message is, in Romania, prevention of hepatic cancer must become a high priority. Access to the investigation must be easier and close as possible for potential patients. In this moment, access it is just in Universitarium Center, and I think if you have access in much more hospital will be easily. Also access to the therapy as part of the prevention. In case of the viral hepatitis should no longer be a problem. Also in this moment, we don't have from 3 months access to hepatitis C therapy. Involvement of family doctor and assuring the free testing necessary for each potential patient, it is also essential in prevention. lifelong screening with semi-annual ultrasonography with or without alpha-fetoprotein testing in patients with cirrhosis and selected patients without cirrhosis. It is recommended by Romanian specialists for all at-risk groups, and it is in all the time, or our gastroenterologists have possibility tell to family doctor and the patient to have in mind this. Some steps are being taken. Medical staff are preparing. Patient associations are here to work in collaboration. It is necessary for hepatitis and liver cancer to remain a priority in EU medical agenda because COVID-19 increases the number of the patients with liver problems, alcohol, fear, or going to the hospital or limited access. It is for us the main problem. And we think the European authority must get involved as a priority in countries such as Romania and support them in carrying out information and screening campaign. Just to give you one example, in this moment, we implement in Romania Libero 2 East and Sud, and before with Libero 1 East and Sud, we're starting a campaign when we training family doctors, and it was preparing a national registry of hepatitis. And now with Libero 2, also with European funders, we test the person for viral hepatitis and save lives. We are testing before more like 2,000 people from all the country, and we continue to testing. And I want to know, for us, European funds, it is the key to solve the solution and to have registered and to help people. Together, we are part of this road. And we think liver cancer prevention and equitable access to the necessary investigation and treatment, no matter where are in the European Union, must to be a priority for all. Thank you for your attention.
Yeah, thank you very much, Marinella Debu. And all ELPA representatives from these very interesting insights from your countries. So we are now coming to our discussion round, and we entitled this discussion, "What can we achieve together on cancer prevention action needed at the EU level?" So, and we will have two key opinion leaders from the European Commission. First, Mr. John Ryan, and John Ryan is a Director of Public Health, Country Knowledge and Crisis Management, DG Santé, and Ms. Brigitta Sakardus. She's a rapporteur of the European Committee of the Regions and the Interparliamentary Committee meeting on Europe's Beating Cancer Plan. So it's really great that you're with us. Thank you so much. And I will invite first Mr. Ryan to present on the work of the Commission related to Cancer Plan, and then to you, Mrs. Sakardus, to underline the importance of commitments at regional level for the implementation of the plan. So please, Mr. Ryan, first.
Thank you very much, Professor Berg, and it's a great pleasure to be here with you today, and I've listened with great interest to the presentation so far. The Europe's Beating Cancer Plan was an initiative of the current European Commission, addressing cancer in a fairly integrated health in all policies approach, I would say. We are, of course, and we were, of course, aware of the impact of liver cancer on the lives of patients and also on our health systems, which, as you know, at the moment are under severe burden. So this is a factor which also needs to be taken into account. And when we were drafting the cancer plan, the Europe Beating Cancer Plan, we tried to identify actions on prevention in the area of early detection and screening, on diagnosis and treatment, and finally on quality of life of patients and survivors. So through this, the Commission tried to identify actions which would have a value added at European Union level. And we hope that through the implementation of the Beating Cancer Plan over the next 7 years, the burden from mortality and morbidity in respect of liver cancer will be favorably influenced, shall we say. So since the adoption of the cancer plan earlier this year, we have been careful to try and mobilize involvement of anybody who could help with the implementation. For example, we have a group of member states which has met already many times to discuss the individual actions identified and to make sure that these actions can be properly carried out at the national level. As I mentioned, it's a One Health approach. So we have actions in the cancer plan which concern taxation, which concern the workplace, which concern the agricultural policy. And therefore, it's important that we involve these policy departments. So the Commission as a whole has been brought together in a group to follow the implementation of the plan and to make sure that all of the actions we promised to do will be implemented through the different policies. And finally, and perhaps most importantly, we have established a group of stakeholders. So the Stakeholder Group invitations have been sent out. We're receiving applications now from individual groups who wish to join the stakeholder consortium or grouping. And we hope to have the first meeting in a few weeks' time as soon as the membership is stable. So you can see here, involving the member states, involving stakeholder communities, involving the other policy departments, I think would be really important. Now, we have also started to use our financial instruments to support the implementation of the plan. We have two programs which I would mention particularly. We have the EU for Health program, and we have the Horizon Europe research program. And I think Barbara Kerstens, my colleague from DG Research, from the Directorate General for Research, will be speaking to you later on more in detail on the research program and on the cancer mission there. But I wanted to mention that already this year we have published 12 grants, action grants, publications already in July, and a second round now in October. And we've launched 4 joint actions with the member states. So a total of 16 individual actions which are being financed through the community budget have been launched already this year. And if anybody who is online would like to have details of these initiatives, these financial initiatives, please let me know. We also have some of these which have just been published and which will be still open for participants to join until the end of the year. So please get in touch if you think that there's something where you might be able to contribute. Now, through the research program, there will be a strong boost in research, innovation, in data, in digitalization, new technologies, new pharmaceutical products. These all have the potential to help in respect of the prevention and management of cancer. We need a better infrastructure in place, for example, to have up-to-date and comparable health data on liver cancer. We heard several people talking about the need for better registries. This is something which we hope digitalization and better digital tools will help us to develop. We also have a new knowledge center on cancer, which brings together our existing work on registries. And this is run by the Commission's Joint Research Center. A third initiative in this area is the area of cancer imaging. And we will be establishing next year a big initiative to improve the quality of cancer imaging. Perhaps would be able to contribute as well to earlier diagnosis. And my colleague Barbara will speak in more detail about this later on. On the second area of prevention, which is the topic of this event, I wanted to say that the previous health program, the one which ran up until 2021, has already invested heavily in the support for prevention initiatives, particularly focusing on disadvantaged groups. And this has also been matched by similar investments from our research program, and we want to continue this now in our current financial round. Under the cancer plan, for example, the Commission will help to ensure access to vaccination against hepatitis B, and to treatments to prevent liver cancer associated with hepatitis C. To this end, we'll propose a council recommendation, in other words, a legal text on vaccine preventable cancers to help to address cancer risks associated with hepatitis B and human papillomavirus infections. Under this year's financial spending, which I spoke about earlier, we wanted to launch these action grants, which I mentioned. And some of these cover, for instance, the access to human papillomavirus vaccination and reducing liver cancer caused by infections. And there are also grants to improve human papillomavirus vaccination in the member states. So you can see it's not only a question of making promises, it's also a question of developing and financing actions on the ground in the areas that we have agreed as being priority. So I think as well, we need more ambition in our actions on health promotion and disease prevention. Our colleague from Denmark spoke earlier on about the evidence that's attached to the effects of good prevention. And we are reviewing, for example, the agri-food promotion policy. We have in the agricultural policy in the European Union money which is set aside to promote the consumption of agricultural products. And we want to make sure that that's done in a healthy way. In other words, reducing the promotion of products which are high in fat, in salt, in sugar, and in trans fatty acids, for example, or also alcohol products. So we want to make sure that in a health and all policies approach, we also include healthy messaging in the common agricultural policy promotion. I'd mentioned on alcohol, since several people have spoken on alcohol, that we are reviewing the EU legislation on alcohol taxation, particularly as regards cross-border purchases of alcohol. Whereas, as you know, at the moment, it's rather difficult to control the quantities of alcohol which are brought tax-free from one member state to another. No, not tax-free. They have to be tax paid in the country of origin, but if you go shopping for alcohol, you can find, of course, countries with cheaper rates of taxation and then import those without paying the taxation in the country of consumption. So we're reviewing that at the moment. We're also reviewing the nutrient content of alcohol products, and we're proposing to put warning labels on alcohol products. So you can see we're not entirely inactive in relation to alcohol either, because we're looking at the taxation aspects, we're looking at labeling aspects, and we're looking at the nutritional content of agricultural products, of alcohol products, particularly in the context of cancer. On obesity and nutrition, of course, we're also looking at the EU school fruit, vegetable, and milk schemes in order to make sure that these correspond to the promotion of products and the making available of products which are which are healthy to our school kids. And secondly, of course, on reformulation of food products to try and reduce sugar and salt content of food products. So you can see there's quite a lot going on the nutritional side as well. On early detection of cancers, we have a council recommendation already on cancer screening. This is being reviewed by our scientists at the moment in order to check whether we could extend the screening approach to other types of cancers, and also what are the new techniques which we might use for cancer screening. And we're proposing a new council recommendation, a new legal text next year. On diagnosis and treatment, I'm in a whole series of actions by setting up a cancer training program, an interspeciality cancer training program. This was launched in July, and you can, we would be very happy to provide the health professionals online with further details. There's a structural initiative to link together comprehensive cancer centers in each member state. And of course, our pharmaceutical strategy, which is going to be delivered before the end of the year, will also make a contribution to better innovative treatments and making available of those innovative treatments. lots of people have spoken about inequalities in hepatitis and liver disease, and I just wanted to flag a fairly innovative approach that we've taken is to establish an Inequalities Registry. This is being developed for us by the OECD, and the member states are closely associated. We also hope to associate the stakeholder community. And we hope by doing this that we'll have several reality checks at different points, and that we won't have people ticking boxes too easily, you know, but that we will have actual checks with patient groups, for example, in order to make sure that what the member states are telling us is actually reflected on the ground. I think this Inequalities Registry is going to gain great importance over time. And raising public awareness is also mentioned by lots of people so far. We have the European Code Against Cancer, which is like 12 major messages which were developed by the International Agency Against Cancer. And these include, for example, limiting your alcohol content intake, eating a healthy diet, maintaining a healthy body weight, be regularly physically active. So, and lots of information and communication campaigns built around that scientific consensus. And we want to really promote that as well as part of these efforts. One or two more points, if you can spare me a moment or two. One or two more points. First of all, we have a more general approach to vaccination since 2018, involving as well the health professionals. Nurses, doctors, pharmacists are involved. The idea is to bring everybody on board to try and promote vaccination. And we launched this before COVID. And I can tell you, the problem hasn't got any better, it's got worse. So really we have to try and find ways of continuing this effort to promote vaccination, because it is a very effective public health measure, including in the area of liver cancer. And finally, I'd mention our two agencies, the ECDC, the European Centre for Disease Prevention and Control. I was looking at their page, I was surfing on their pages when I was listening to you earlier on, and they have hundreds of documents and hundreds of recommendations to deal with prevention of hepatitis, in particular settings as well. You were talking about vulnerable groups in prison settings, for example, in migrant settings. I don't want to stigmatize anybody, I'm just saying that, you know, there's a special need for a special approach in some specific settings, and the ECDC has developed a lot of science on this, but also surveillance and so on. And finally, of course, the Drugs Centre, the European Drugs Centre in Lisbon, has a huge focus on elimination of hepatitis. So I really think that the European Union is not inactive in this area. There's a lot of stuff going on, and it's a pleasure for me to have the opportunity today to say a few words about this. Thank you very much again.
Yes, thank you, John Ryan. Very informative, and of course, it's quite impressive what you have told us, and it's needless to say when I think all the medical societies saw what are you doing with the EU for Health, and especially really with this very comprehensive and ambitious Beating Cancer plan. We all felt this is very timely and a very important initiative. So it's my pleasure and privilege over to you to again introduce Brigitte Sakridis from European Committee of the Regions and the ICM. So please, Brigitte.
Well, I think we now have a very good example how important it is to work multi-level governance. As a policymaker, we have to have contact with each other and help each other out to, for example, the cancer plan. And just so you know that the member states, they are responsible for financing, organizing the healthcare system. But in 19 out of the 27 member states, it's the region or the local authorities that have the primary responsible for healthcare. I myself, I'm in Sweden, in the region of Dalarna, and I'm responsible for the healthcare. So it looks in many other countries in Europe. And EU is responsible, like you heard from John Ryan, can help us on the health issues. And I think EU has done a great job when it comes to smoking. Who could think that people have stopped smoking in restaurants? Well, this is now the case in the 27 member states. Smoking is not allowed in the restaurants. And I think we can work like that also when it comes to alcohol. We can do much more when we can have campaigns like we had for smoking, the non-smoking generation and so on. We can have campaigns about this because alcohol is very, as you know now, very important to reduce the alcohol drinking. And in Sweden, we have an example, but I know the Nordic countries are really different, but it's not so easy to have access to alcohol. We have special shops that is open special hours. And that's one way to try to decrease the alcohol problem. And also, John Ryan was mentioning labeling of alcohol. I think this is really necessary that we put this forward on the EU level. When it comes to obesity, of course, city planning, and that is done usually on local and regional level. It's important to be able to move. We know that it's so important that we are active moving for our health. And there we must have good pathways, parks where you can run and have access to sports. And I would tell you in my region, what we have done is that we have now a commitment together with the sports academies. So they go into the schools and make the youngsters start to move much earlier. So if you want to have a change, start with the youngsters. And that's what we are doing. We ask the sports clubs to go into the schools and do more work there. So this is really important. And also chemicals that are causing cancer. EU is working great job there too, trying to find and take away chemicals that are not good for our health. And also the pollution, EU has a towards zero pollution for air, water, and soil. That's also very important to reduce cancer. And we also, John Ryan also talked about what we can do with agriculture. What we eat is important. And I think it could be more there about nutrition labeling, so we know more what we eat. And also as a policymaker, I think it's really important to where we have our advertising, so we don't advertise bad things, that we have a restriction there. What I also is proud of is that really stress the cross-border healthcare, that if you don't have the ability to get health help in your country or region, you can go to another country. So the cross-border care is really important, that we can stress even more. And what I also was happy to hear is that we have cancer centers that we should try in Europe on European level to put data into a common center. In Sweden, it's great because we have cancer centers, and they are divided into 6 centers, and the regions can go there and find digital, and also they have meetings, because it's really important that will be top-down knowledge. I mean, the health workers that meet the patients should have this knowledge, what to do, so it will be early detection. What should they look for? So here we have to have a top-down look at this. So these cancer centers for Sweden has been very, very important. So I hope that in each country you have cancer centers, and that you can that we also will have this and give information on EU level, and we have standardized programs. If you get a liver cancer, for example, you should have a standardized program, what steps you should do. That is national now in Sweden, and I hope you will have that also in your countries. And the most important thing is, of course, to empower each citizen, include ourselves, to be able to find information if we are worried, if we get cancer. That's why digital knowledge is so important. And EU is working for the digital issue, and so we do in national and regional level. So we all have easy access to knowledge. So digitalization is also a key to solve more of the cancer problem. So thank you, and I wish you all that work with cancer, the health workers, good luck in your work. And also we have to get more health workers. That stands also in my opinion, that we all need to get more people interested to work in the health sector so we can help our patients and our citizens. Thank you.
Yes, thank you, Brigitte, very much. And this is really something also, of course, EASL may want to contribute, you know, when you ask to have also more health professionals to give advice, to be in contact. And we also tried a lot of, you know, having campaigns about the risk of hepatitis B or C and do a vaccination. But what we realized is that, you know, if you do these campaigns, people looking at it, watching at it, and sometimes we had it in the cinema or I don't know, before a movie starts, that people do not feel it concerns to them, you know. It's always the feeling, well, it belongs to someone else. And I really agree with you that empower the individual, that he get a sense on the individual risk factors, because we are not only talking about liver cancer, that's for sure, but we feel that liver cancer could be really this role model. And I think there's also the idea of liver health, because it's the organ of metabolism that also helps all the other cardiovascular disease if you have not a fatty liver and so on. But I would like to open now the floor to all the speakers and to ask questions. I can perhaps start with one coming here from our audience, and it's related to the Brexit and whether the UK will be now excluded from all the EU initiatives to address these very important problems, or there's still scope for engagement and collaboration. I don't know, John or Brigitte, would you like to answer first? John?
Yeah. So as regards the financial instruments, each financial instrument has a separate set of rules as regards UK participation. The UK basically have to buy in to individual programs. So if there were people from the United Kingdom interested in participating in an EU program, they have to check whether the UK as a country has decided to purchase its membership of that particular program. It's the same arrangement that we have with Turkey or with the accession countries, you know, that we calculate an annual amount and then they can join. Of course, it's possible very often to participate on a voluntary basis, but that's maybe not so interesting for some people if they don't actually have access to any of the funds. The third point I would make is that, of course, anything that's produced using EU money is publicly available. Everything is available as a published result. And of course, I guess that many of the European associations are European associations. They include people from within and without the EU. So we have colleagues from Israel online today, for example, and it's traditional, I think, in public health that we have an open door policy rather than a closed door policy. The UK is participating with the European Centre for Disease Prevention and Control in the sharing of alerts, for example, so that we know what's going on in terms of communicable diseases. So there is still a level of cooperation there.
Yeah, thank you very much. We have a question from Pierre Naon from France.
Hi, can you hear me?
Yes, we can hear you.
Yes, hi. Hi, everyone. Thank you very much, Mr. Ryan, for this very, very important information. And I was really pleased to hear about the will to promote grants for action programs in cancer. And I saw the grants that are currently being communicated around early detection for cancer. What would be your advice for our community if we wanted to participate to this grant program? Should we do it under the EASL patronage? Or do you have any advice? Because this is a very, very competitive field on this matter. And how do you take into account the heterogeneity of all healthcare level systems in Europe, in European countries? Thank you.
Yeah, John, please.
Yeah, so the process is as follows. We have a legal text which sets out the obligations or the ambitions of the cancer of the financial instrument. The financial instrument, in this case, we're talking about the EU for Health program, but we could be talking about the Horizon Europe research program. Then the Commission develops a work plan for each year. So N+1, we develop a work plan. The work plan for 2021 is obviously already adopted. And that's, if you look in the chat box there, I've published the actual details of the calls for proposals. The implementation of this work plan and the calls for proposals are published by an agency. So we don't do that. We actually set the targets, if you like, but the actual individual project applications are then evaluated by independent experts. So it's not by talking to me that something is going to get through or not get through. It's a completely transparent and independent process with outside experts who evaluate competitively each project. And my advice would be that the more partners you have in a project, the more substantial your chances would be of success. If you have, it's a European program. So in other words, if you have 3 member states involved with minor impact, shall we say, it might be very interesting in a specific case. But in the case of liver cancer, I think we need to have a much wider approach. And of course, in that, the more partners you have in, you can also factor into the project countries with higher or lower health systems resources and so on. So it doesn't all have to be the same solution for everybody. Yeah.
Yeah, thank you very much.
I'm asking everybody, but
yeah. So we have a question again from in the chat, and this is for you, Brigitte. Are the protocols for handling liver disease available outside of Sweden?
Good question. I don't know if they are translated to English, but of course you can look for the. I can write it down in the chat, the address where you can find this center. I can write that down.
Okay, thanks a lot. We will forward it, and we have 2 questions here from our speaker. First from Milan, and then from Maria Rake.
Thank you very much, Thomas. My question is directed to Director John Ryan. Hello, John. It's nice to meet you that I can see you today. I'd like also to ask about the countries around Europe who are applicants to be members of the European Union. We listen a lot that we have a lot of approachable funds. We can use it also in the area. But do we have a chance to applicate, like let's say, directly from this country, like North Macedonia, Serbia, Bosnia and Herzegovina, or we need to have consortium together with the cross-border countries from European Union, like Greece, Bulgaria, and etc.
Well, I think there are 2 separate cases here. First of all, if a country from an accession country wants to join a project under an EU financial instrument, might be the research program, might be the health program, the accession country in question has to have access to that particular program. So that's the first thing to check, whether the country in question has access to the financial instrument. If they do, then they participate more or less on the same level as everybody else. So you're treated like a member state from the beginning, once you're admitted to the access to that program. The other scenario is that you want to do something on liver cancer, either in your own country or with a group of other concerned countries in your region. And there we have specific funds as well, which are outside the health program, outside the research program. These are what we call the neighboring or the accession funds, which are specific funds. And there you have a very strong case if you can show that it's something which the European Union itself is doing. So in other words, you could say, based on the Europe Beating Cancer Plan, based on the actions that are specified there, we want to do something using the neighborhood funds in our country. And that will have a strong chance of success. We've done this already for antimicrobial resistance, for example, in the Balkans. In the Western Balkans, we've made a major investment in the Western Balkans based on our own EU action plan against antimicrobial resistance. So please contact me separately on that if you wish, or with your colleagues, and we'll get you the information.
Yeah, thank you very much. I realize that we are, well, a bit beyond the schedules, but I would like to allow for 3 additional minutes because there's some additional questions, first from Maria and then from Moika.
Thank you, Thomas.
And then we have the lunch break. Yeah, please. Okay.
Thank you, Thomas, for the introduction, and thank you for the presentation. I'm an expert in liver cancer in Spain. Here we have a lot of activities around the patient management, but one of the things that I'd like to know from a European level, if you could consider the patient care as the sooner of the patient. Now we are asking for prevention cancer. We will have some strategy for that. Cure of hepatitis C is one, stop smoking and also alcohol intake is another, also hepatitis B. My question is, have you could consider a strategy that prevent liver cancer and also a screening program for those patients who receive this strategy? Because maybe in this direction, regardless of the heterogeneity in Europe, we could have a better outcome that we have at this day. Sometimes we are focusing prevention, but then the patients are at risk, low risk, but still have a risk. This is something that you could consider at a European level?
I don't know, Brigitte, would you like to answer, or?
Jan, both of you.
I was just trying to chat the cancercentrum.se. Now everyone has it. Can you repeat the question, please?
My question is, we have some actions to prevent liver cancer from European level. Do you plan to consider a strategy for those patients who were treated as a prevention cancer? My specific question is prevention and also follow-up with surveillance strategy for them.
I don't think that on the EU level, we don't do it at the regional level. Maybe John Ryan can give an answer to this. On national level, yes. I don't know on EU level. Maybe Ryan can give an answer to that.
Yes, thank you very much, Maria, for this idea. I would only say in response to you that this cancer plan is an open plan, it's not a closed plan. At the very beginning of my intervention, I said that we were encouraging the participation of stakeholders. That means medical professionals and patient groups. We have an open call at the moment for membership. We're inviting people to join us on this. So if you have ideas as to where you think our focus should be, if you think that something is missing, if you think there are gaps, please let us know, because it's very difficult for us to know everything that's going on all over Europe. You are on the ground, you're dealing with patients, you're treating patients, you're trying to prevent the disease. So it's really very good if you can intervene as well with us, give us your ideas, and working together with associations like the ones who are organizing today's event to actually come forward with concrete ideas and proposals, which we can then support.
Thanks.
a very important point. A very brief question and answer, please, Moika. You're muted. You're muted, Moika. Moika, you're on mute.
Yeah, I have a question. Thank you. Sorry. I have a question for Mr. Ryan. First, thank you for a very nice presentation. I just wonder, is EU planning to support the WHO viral hepatitis elimination strategy? And if so, what kind of support could be expected by the EU member states? Because, you know, there are huge varieties throughout Europe regarding the management of hepatitis C. Several real-life data are showing that. So is there any support going to be expected from the EU?
Yes, we had a meeting. We had a meeting 2 weeks ago with the director of WHO Euro, Hans Kluge. And earlier on this week, we had a meeting with the Director General of WHO in Geneva. So we are talking to each other. We are looking to see how we can work together on different files. COVID is a very good example where we work together every day. And I would say the member states and the WHO are aware of what we're doing, and we're aware of what they're doing. So there's a very close cooperation, in fact, with the international level. And we will use our financial instruments, whether it's in research, in the EU for Health programme, or also in the structural funds, the various funds which have been put aside now for COVID recovery, to try and strengthen our member states. So that's the only answer I can give at the moment, but there is a very, very long tradition of cooperation with WHO.
Thank you.
Yes, thank you very much. Well, Marco, from your point of view, is there anything to add before we conclude the session?
So now I just wanted to say thank you for being here. Thank you for answering all the questions. I see we have some more questions in the chat. I received several questions through the email and other means of communication. So it seems that your contribution to this event was extremely valuable, and it sparked a lot of interest. So I'm hoping forward that we will continue with this pace. And in the name of liver patients from Europe, I would like to thank Director Ryan. We see you your work for several years now, and we see a big step forward and progress, and we hope that you will continue there. In regards of the all panelists from the patient side, thank you for the presentations. We hope to continue, and after the lunch we will see more concrete examples on testing and screening and what we can do there. But from my side, thank you. I'm giving the floor back to you, Thomas.
Yes, thank you very much. And I also would like to really express my thanks to all of you for excellent talks and having this very interesting discussion. I would also have loved to touch a bit on these issues we always have with bureaucracy, data protection rules, and what is meant with an interventional and non-interventional study, because it really creates sometimes really real obstacles in working together, having this registry, and perhaps we can touch on that in the second part, but otherwise this could be also something for bilateral communication. So I want to conclude. I think that we have shown in the first part that most patients in Europe and worldwide who suffer from liver cancer also suffer from a chronic liver disease. And I think it was also shown that it often takes decades for chronic liver disease to turn into a malignancy. And these decades could have been used to treat and often cure chronic liver disease and thus prevent liver cancer from developing. So unlike many other cancers, liver cancer prevention in the EU therefore focus really on a very specific group of population. And these are the people with chronic liver disease. Therefore, liver cancer prevention also means early detection and treatment of chronic liver disease. And I think, Moika, we have seen your example from Slovenia, how effective this can be. So even after a couple of years, we see that the numbers are declining. So really a proof from real world. So thank you again. I wish you have a nice lunch break, and we reconvene at 2 o'clock. Thanks to all of you. Bye-bye.